estrogen's role in mast cell regranulation. Do we see differential LDN responsiveness in MCAS patients based on hormonal status? And could LDN be used to stabilize mast cells by modulation of neuroimmune crosstalk in a sex-specific manner?
Oh my goodness, I love that question.
Okay.
Oh my God, who? I did not. I actually did not. No, is it someone here, or do you think is it live streamed? We don't know. Okay, whoever wrote that, it's awesome. That gave me all the feels. So all of them, and it means that all of us are affected with patients with these conditions, right? I mean, it is just exploding. So 100% yes is the answer. That's the short answer. 100%. So we know that the more, and by the way, estrogen. So the toughest part is I straddle both worlds. I'm a very short atlas, right? Very short, straddling with my little legs, straddling the allopathic world and straddling the natural world, which we should all be just talking about what works in medicine, right? But in the allopathic world, they are very much against terms like estrogen dominance, right? Estrogen dominance doesn't exist. Well, it sure as heck does, but it is not a diagnosis, okay? So let me be clear when I use that term, right? But we're talking about a relative imbalance in estrogen metabolites. And we can talk about from the microbiome perspective, for instance, if a person is chronically constipated, they're going to be reabsorbing up to 30% more of their estrogen. Let's just talk about that via microbial production of beta-glucuronidase, okay? Because E. coli's do that. Aside from the LPS problem, if a person, a woman, for instance, has low progesterone, and the more she is toward her period, in the luteal phase, she's going to be higher and higher estrogen. She is going to have more histaminergic problems, just naturally. So estrogen and histamine go hand in hand. And I absolutely love low-dose naltrexone's mast cell stabilization properties, and I get into a fight when Leonard Weinstock is here about how strong of a mast cell stabilizer it is. And the answer is that it depends on the patient. But we need to use every single tool to help stabilize mast cells in these patients who are just degranulating like crazy. And when mast cells degranulate, they release 1,050 different mediators. So it's not just a histamine problem or a leukotriene problem, but we release endogenous heparins, for instance. There's only 2 labs in the country, as Dr. Weinstock said, that can actually measure that. So you've got easy bruising, you've got patients who are just super inflamed in so many areas, and histamine equals pain. So these patients are in a lot of pain. And if you take women who have estrogen problems like in endometriosis, or there are receptor abnormalities like adenomyosis as well, they are really, really inflamed and they are in pain. And utilizing LDN, as long as it's tolerated, and coming back to the question, we usually have to start with very, very low doses. Paradoxically, some of my patients who have endometriosis along with EDS or mast cell, they tend to need higher doses, or they have a very strong pain component, a chronic pain and trauma component. And also dissociative conditions, like with that trauma, they need higher doses. It's really knowing kind of the flavor of that patient and the way to go. And it's becoming extremely nuanced to prescribe and find that maximum effective dose. So you'll talk to each clinician that speaks about LDN, and you'll find they've got different protocols and different ways of seeking out, that specificity and sensitivity for the patient.
I'll just add one quick adjunctive therapy to that I found works really, really well, because I used to be extremely estrogen dominant, gynecomastia, the whole issue, TBIs, all the things. I could not regulate my hormones for the life of me. LDN, and then also an aid from an enzymatic perspective to reduce the immediate effects of histamine, was adding in diamine oxidase. So if you add diamine oxidase, it'll actually degrade histamines in the bloodstream itself. It'll lower the reaction or being hypersensitive. It's a temporary effect, but coupled with LDN and then balancing out your hormones, which is a whole 2-hour presentation of itself. But I found that adding diamine oxidase kind of gives a faster way to balance out the effects of LDN over time. Do you have anything to say to that? It's like one of my favorite things to add.
I love DAO, and there are now actually, so there's only one. It's animal kidney based is the DAO version. Some patients are sensitive to that in my practice. There's actually a plant version of DAO now too. One of my patients that did not tolerate the traditional porcine, because also she has a thyroid condition, and via molecular mimicry pretty much reacts to all kind of animal type products. We found a plant-based one for her that worked really, really well. But yes, I use all of those things. I use cromolyn, I use ketotifen, I use bromelain, I use high doses of quercetin, I use leadweolin. By the way, you've got to be careful when you use high dose quercetin because it can lower ferritin. So you got to be careful with that long term. That's another thing that we can struggle with. You always have to know all of your, pharmaceuticals and nutraceuticals. And also, he made a really excellent point about rotating things in and out. Same thing with things like probiotics. Friendly neighborhood microbiologist here. We want to not overuse probiotics. That's another thing. Remember, most of the time probiotics don't colonize. We use them for the immune system modulation approach, okay?
I'm just going to jump in and add, there's a whole bunch, and I think you've got your hand up, so you may have a question in there. I'll bring it back. But just while you stroll back, we do know that there's a lot of information about hormone imbalances driving inflammation and driving that sort of change in that set point and more reactive immune systems. We can actually see this in an aging population in people who are going through perimenopause, menopause, andropause. Men are not immune from this. We can actually see this entire inflammatory cascade shift. And that's actually a pre-existing sort of like almost aging perception of hormone imbalances. But then with these MCAS patients or these highly reactive, sensitive patients, we can almost see like, oh, let's just check your hormones before, because it's a feedback loop that if you're inflamed and dysfunctional, your immune system is going to change your cortisol levels, which will then cause a whole hormone imbalance cascade. And then you've got your blood sugar that is also sort of vaporizing these patients. And so when you were talking about endometriosis and PCOS, we also see this in interstitial cystitis. We see this in vulvodynia, that they can have hormone imbalances, and we address that, and it's easier to treat. And so there's so much overlap and interplay. So, and then that also relates into obese patients and morbidly obese patients. You can actually see significant hormone imbalances in those patients. And our drugs just don't work, including up to, but more recently found, GLP-1s just don't work in patients with hormone imbalances. They're just going to keep eating. And, but to the benefit, women have a better response to GLP-1s when their hormones are